So the next speaker is going to share with us insights about prostate cancer. So Dr. James Moeller, thank you. Oh, hi again. So the title of this particular presentation is Clinical Pathways for the Individualized Management of Prostate Cancer, Addressing Disease Diversity with Emerging Therapies and Tailored Treatment Plans. And this particular educational activity is supported by an educational grant from Astellas and Medivation, which is a Pfizer company, as well as Bayer Healthcare Pharmaceuticals. So nice to see you again.
So thank you. Okay, so this is who I am, and I don't have any disclosures other than I work for NCCN, and my wife and my children and me are very poor. So these are our learning objectives that you can read. And I think prostate cancer is very salient to many of the points that were made earlier, especially the gentleman's desire to look at the whole spectrum of disease. And I, like Bob, I'm a surgeon, so I look at the whole spectrum of disease. Okay, so we're going to look at the spectrum of prostate cancer disease, and then they asked me to focus on the new treatments for metastatic castration recurrent prostate cancer. And then we're going to look at pathway construction and adherence, and I'm going to finish up with something about the patient perspective. So prostate cancer is very interesting because it's very complex. There's very little data that informs most of what we do. And so there's tremendous controversy because everyone can be right or wrong depending on who you listen to. There's several variables, though, that are well accepted that can be used to counsel patients, and I like to say right-size treatment. And guidelines provide a very good framework to do that, and also a good framework on which to base care pathways that I've actually been doing since 1992. So this is going to be the outline of our talk. We're first going to look at prostate cancer biology, and this is one of the rare tumors where you look at the cancer at low power, and the cancer's ability to form glands remains the most prognostic factor. So Don Gleason proposed this grading system, and it still is the best predictor of outcome. And then you have to stage the patient. For this, you use physical exam and some imaging and some biopsy results. And most of our patients are PSA detected or present with a lump. With the decline in use of PSA, we're seeing more advanced disease. And I like to make things really simple. So prostate cancer is good when it's low grade, low volume, and low PSA, and PSA is rising slowly. It's bad when it's the opposite. About half the patients are in between, and that's why there's so much controversy. Now, what about the incidence and mortality? So every 3 minutes, someone's diagnosed with prostate cancer in America. So this is the most common diagnosis of cancer in men. And then every 20 minutes, somebody dies of prostate cancer. So you see immediately a huge problem where there's a 7-to-1 difference in the mortality versus the incidence. So this is a very slow-growing tumor. So the annual adjusted incident rates peaked or demonstrated a peak when PSA was discovered, and then you culled through the population, and then everything kind of leveled off. And that's where we are today. And since PSA was discovered, the mortality rate has fallen dramatically, and there is no other good explanation for this. So many of us are very worried that the decline in PSA testing is going to shift the disease back toward where it was in the 80s, where most men presented with metastatic disease. So there's tremendous controversy about the early detection guidelines, and this is your first question that's not in that ARS system. This is just for you to do. Since the discovery of PSA, the death rate from prostate cancer has done what? And the answer here is C, because I just told you it decreased 40%. And so we don't want to throw out the baby with the bathwater. So it's very interesting to look at the evolution of guidelines for PSA testing. We started out when the U.S. Preventative Services Task Force said that routine screening was not advocated, especially in men over 75. And then we had this evolution over time where all the other groups followed suit and kind of narrowed their indications for who should be screened. And we pretty much everyone accepted that you shouldn't screen really old people. And then the D rating came out from the United States Preventive Services Task Force that said that no one should be screened, and everyone got all upset, and then things were focused a little more. And I still like the NCCN 2011 recommendation, which is no longer in existence, as being the best way to do it. I'm going to show you why. So the current recommendation has been simplified and does away with risk assessment. The U.S. Preventative Services Task Force draft, not yet finalized, but changed the rating to a C now. So we went from a D to a C. So we're getting better. And that is, screening may be appropriate for men at higher risk. And so the total cost of prostate cancer screening is quite high. So this is important. When you look at it relative to other things we do, it's fairly reasonable. But it becomes better if you do it more effectively by directing your screening at men with a family history. The most powerful predictor of developing prostate cancer is if your brother has had prostate cancer. And therefore, I think we should begin to screen men with a family history a little earlier. And the other thing we can do is appreciate that African Americans have an increased incidence of prostate cancer. And when they get prostate cancer, it seems to be more aggressive, and hence they're more likely to die of it. And we're still trying to figure out why that is, and the bottom line is nobody knows. So the use of PSA for early detection is most appropriate for, and you can read the answers there, and everybody will agree that the answer is all of the above. So this is using a risk-stratified approach to make PSA work better and continue to maintain that decrease in death rate that we've seen. All right, now what about guidelines? Because that's most of what I've been supposed to talk about. Well, there's one randomized study of treatment versus non-treatment. One in the history of urologic oncology. And that's the Swedish radical prostatectomy study that basically shows that radical prostatectomy shows a reduced prostate cancer mortality. There are no other tests. There's no test of radiation versus watchful waiting, radiation versus prostatectomy, nothing. So again, we have very little data. We also know from the Tyrol, Austria study that there is a lead time bias that was introduced into America by the adoption of PSA, and so that we can find prostate cancer an average of about 10 years earlier. So to make Sweden analogous to the United States, you have to add 10 years into the lifespan of a prostate cancer to determine whether it needs to be treated. So we were going merrily along saying, okay, let's detect prostate cancer and treat everyone with radiation or operation, until this explosion occurred on March 26th, where back-to-back articles in the New England Journal indicated that we were greatly over-treating men with prostate cancer. In fact, you needed, in the Canadian study, to treat about 100 men with low-risk prostate cancer to prevent one death. In the American study, one of those two New England Journal articles, there was no survival benefit at all from treating men with either radiation or operation. In the European study, it was a little better. There were 48 PSA-detected men would prevent one death. And if you looked at the most mature of the subsets of that study, it was only 12 men needed to be treated to prevent a death. So the bottom line is you have to recognize in prostate cancer that you're treating a lot of men unnecessarily to prevent a death from prostate cancer when you're dealing with early detected disease, hence all the controversy. So active surveillance. Why should we look at watching men with prostate cancer? Well, the chance of having prostate cancer detected at autopsy is about your age. So I'm 64. I have a 64% chance I'm standing here talking to you with prostate cancer, and I slept reasonably well last night, except for the people in the hallway at 4 o'clock this morning. So the best estimates are somewhere as many as half of the people that are PSA detected don't need to be treated at all. So I'm very proud of the fact that NCCN responded to this. We looked at the risk of treatment and the benefits and recognized that if we could avoid safely treatment in many of these men, we would save them from side effects from treatment that was totally unnecessary. And so in 2010, we divided the low-risk category into very low risk and low risk using the Epstein criteria from Johns Hopkins. And then the second thing that was very controversial at the time is that we made active surveillance the only recommendation for men with low-risk cancer that had a physiologic life expectancy of less than 10 years. And for very low-risk prostate cancer, if your life expectancy was less than 20 years. So we were reaching down into the early 50s for men with very low-risk prostate cancer that you could not recommend treatment. So, but, oh my word, the cancer's spreading while you're sitting here counseling the patient. And this study published by Dr. Nam, based on the long wait times in Canada, was the fuel for that argument. And this got a lot of people used this to refute offering patients active surveillance. But there are numerous well-done studies that show that there is no harm from watching men with prostate cancer for a period of up to 2 years. And in fact, if you're put on active surveillance and demonstrate progression and are then treated, your cure rate is actually higher than the best you can match men in a UCSF study. So in 2011, we were asked to provide some more guidance about how to put men on active surveillance and, more importantly, how to convert them to treatment. And the truth of the matter is that's still very difficult to do. There's a tremendous argument about what constitutes progression, and you can choose to believe a whole variety of ways of doing this, but what we really need is a better biomarker or more clear-cut and well-accepted criteria for progression. In spite of the uncertainties of how to convert men to treatment, only about a fourth of them are converted to treatment. And I said that it is at no harm of cure rate. So this has really become, changed the way we deal with low-risk prostate cancer. Okay, but wait a minute here. I told you a moment ago that someone's dying every 20 minutes. So we got the people who love surgery. We can do it open. Then we could do it laparoscopically. Now we have robots. Perhaps robotic surgery gives a little bit of an advantage over open operation. The patients love it because they recover quicker. We can do radiation. The radiotherapists have responded as well by developing better brachytherapy so you can put the little seeds in more precisely. You can also not just do that old-fashioned radiation, but you can conformally shape your beam. And better yet, you can do it by IMRT, deliver beamlets of therapy that you can really precisely sculpt to the prostate. And this allows curative doses to be given with less toxicity. So we ought to just treat everyone, right? Well, wrong, because we talked about the risks of treatment. People still die of either operation or radiation. And what really bothers the patients are the chance of incontinence and impotence that occur even in the best of hands. And this is from the NCCN guidelines, and whenever I put this up, everybody argues about it, and I say, give me better outcome data, and I'll change it. And there is very little long-term outcome data for the side effects of treatment. So how do we right-size treatment? Well, this begins because our men are average age of diagnosis of prostate cancer in America is 69. This begins with an estimation of life expectancy. And then we need to risk stratify, and then we got to remember that the first thing we need to offer is active surveillance, and then tell the patient what's the chance that he'll be cured by curative therapy and what are the side effects, and most importantly, what would be the benefit in terms of his cancer compared to his chance of dying of cancer if not treated. So how do we do this? So everybody always says life expectancy, oh, you can't tell how somebody's going to live. But we have all these tables that can do it. And then we don't want to use chronologic life expectancy, we want to use physiologic. So you can either deliver these large questionnaires that take forever, or you can use the Gestalt method, and you can just adjust based on whether you and the patient agree that they're in the best 25% or worst 25% of health, and you move their life expectancy up and down. So I'm going to make you all urologists and radiation oncologists for a minute. And we're going to treat a 65-year-old African-American man who happens to have a life expectancy of 16 years. And we're going to look at an example of somebody who enjoys really good health and one who enjoys really poor health, and then we're going to figure out what treatment they should have. So we're going to estimate the time till they die of cancer by looking at the Gleason score, the tumor volume, and we'll do it two ways. We'll do it based on the Swedish experience and based on the PSA doubling time to predict the rate of growth, and we're going to calculate how long it's going to take for that cancer to kill the person so we can help them figure out what their chance of dying of prostate cancer is. So the more personalized way to do this is to calculate the PSA doubling time instead of just using the Swedish tables. And we're going to assume that this 65-year-old has an average prostate cancer. The average doubling time in America is 4 years. So we're also going to assume that he was diagnosed because his PSA was a little high. We'll just say 6. So his PSA will reach 116 years, and then he'll have a remission from androgen deprivation therapy that lasts 5 years, and so he's going to die 21 years from now. So he's going to die when he's 86, being diagnosed at 65. So here we start off with this example patient, and we're going to figure out how we should use the NCCN guidelines to recommend care, and his health is excellent. And so these are your 5 choices for treatment. So everybody figure out what they think this person should have. All right, so this is the way I look at it. He's going to die of prostate cancer in 25 years. His life expectancy, adjusted because I told you he had excellent health, is 24 years. So his chance of a cancer death with excellent health is about 50%. His cure rate is 83%. So we can reduce his chance of a cancer death from 50 to 7% by treating him. When I give this talk and we do the ARS things, most people pick active surveillance because I just talked about it. Well, that's wrong in this case because he's so healthy, and his PSA doubling time shows a significant rate of growth. So his choice is really treatment, and you can argue all day long about which treatment is best. Now let's change this guy to being poor health. He has a whole diabetes and had a stroke or whatever. And so now what's the best choice of treatment? So in his case, his poor health means with a life expectancy of 8 years and his prostate cancer is going to kill him in 25, he has a 0% chance of dying of cancer. So what happens to this guy in America? Almost everyone gives him radiation. Some people take his prostate out. And you're going to do really well because his chance of dying of cancer was 0. So all you're going to do is cause him side effects. So the proper thing here would be the option 5, active surveillance, which in his case is really observation. Now let's make the health of the patient average. And now what are you going to choose? So again, the way I look at it is with average health dying in 16 years, his cancer is not going to kill him for 25, so he has about a 10% chance of dying of prostate cancer. So by curing him, you'll drop that chance from 10 to 2%. Now he's got to decide what's it worth to him to have the side effects. And so prior to 2010, with a 10% chance of death, you could offer him treatment or active surveillance. The only treatment recommendation, though, from 2010 on is active surveillance. And so to treat him would be wrong. All right, so the NCCN guidelines, we're now switching to more advanced disease, and I put these up only to say that when the new guideline comes out, probably next month, all the advanced disease section is going to change, so just be ready for that. So now I'm going to become a medical oncologist, and androgen deprivation therapy is actually what I study in the lab. And I love to show this picture because on the left, most people, I live in Buffalo, think those are chicken wings. Those are actually testicles when we used to take them out. And that's kind of like the old Volkswagen. So Volkswagen's evolved. And has anyone seen that top left Volkswagen? That is only sold in Europe. And that is not what I think of as a Volkswagen. So androgen deprivation therapy, too, has evolved. And you've got all these treatments now. And so the patients and physicians are very confused about the smorgasbord. And I'm going to try and make hormonal therapy really easy for this group. So the first question is, do you use an LHRH or an LH antagonist? And Dr. Shally developed the LHRH and got the Nobel Prize for that in 1977. It was funny because the only reason I put this slide up is it took from 1971 to 1985, took 14 years to demonstrate to get this into the clinic. And then the antagonists moved along a lot faster. And there's no good study that shows that one is better than the other. And if you use an LHRH antagonist after an LHRH agonist has failed, they don't work. So it pretty much proves they're equivalent. What about a LHRH agonist or complete androgen blockade? And this is another one of these goofy stories that Dr. Labrie did this study and claimed that it showed that flutamide, adding an anti-androgen, increased survival in men getting LHRH. And so all of a sudden everyone started using the anti-androgens in this thing called combined or complete androgen blockade. The only problem was he was wrong in that flutamide didn't do anything when it was added to men who'd had an orchiectomy. So what he didn't know was there was an LHRH flare that boosted testosterone, and probably that was the reason those curves separated slightly. So there is no reason to use an anti-androgen to make androgen deprivation therapy more effective. Now, what about reducing the amount of hormones? If you talk to the men in the support groups, they are furious with everybody putting men who failed operation or radiation on hormone therapy for the rest of their life. And that's because hormone therapy has all these side effects. And the big ones are at the bottom: stroke, heart attack, diabetes. And so there are numerous studies that show intermittent androgen deprivation therapy, where you deliver it until the PSA is controlled, then you stop and you only do it again when the PSA reaches some certain rate. Doesn't change, doesn't affect survival at all compared to continuous administration, and that intermittent hormonal therapy improves quality of life. So, in my opinion, everyone with advanced prostate cancer should be on intermittent hormonal therapy, which reduces costs, improves quality of life, and is a real reason to put pathways in place to encourage physicians to do this, because it's very, very rarely done in America. Now, one argument is, well, they're going to be on continuous anyway. Well, you can personalize the selection of men who can have long periods of time off hormonal therapy by just looking at the PSA response to the first cycle of androgen deprivation therapy. And this is from Maha Hussein's trial that duplicates what I've done for almost 4 decades, and shows that if you have a really good response to induction, you may be off hormonal therapy for several years before you need it again. And this is men who have bone metastatic disease. So what about now when we get to hormonal therapy, the latest big thing, which is to give additional treatment at the time of initiation of hormonal therapy? So there's now been multiple trials that have shown that if you give docetaxel for 6 cycles at the time of initiation of hormone therapy, you can extend survival. And so this has become the standard of care. This was just published a little more than a year ago. Then we've just had the Latitude study published, where they randomly assigned men to androgen deprivation therapy with or without abiraterone. And abiraterone also was shown to extend overall survival. So we have another new standard of care. And it is wrong to compare docetaxel to abiraterone for which one should be given, because there's as yet no study doing that. So we've changed the recommendations for metastatic cancer. We're really trying to encourage the use of intermittent ADT, especially when men are asymptomatic with metastatic disease. By age and comorbidity, if you're younger and healthier, you definitely should do ADT plus something else because of the overall survival benefit. All right, so now I was asked to talk about new treatments for castration-recurrent prostate cancer. So first we have to define it. That's if you're on androgen deprivation therapy and you have increasing PSA, or you have a progression of disease without change in PSA. You must document a castrate level of testosterone, which most people agree is less than 50. And we don't want to call this anymore hormone refractory or androgen independent. It is truly cancer that's come back after castration, which a urologist calls castration recurrent. The medical oncologists call castration resistant because they didn't ever see the patient before they got to this situation. And again, the guidelines will be coming out new. And what I want to do is practically look at what we do in this situation. For a totally asymptomatic patient, you can use immunotherapy, Sipuleucel-T, and this is this lovely cartoon that comes from the company's website. I just think it's beautiful, so I put it on here. And it tells you how it works. You basically, the practical is that you leukapheresis the patient, you send that to the company, who then activates the T cells, and then they're infused back into the patient so that they get 3 infusions 2 weeks apart. Nobody thought this would work, and darned if it didn't. So now we have 2 different immunotherapies coming down the pike that hopefully are going to be better. But this is going to be my recurring theme. This is the time to disease progression. It was actually worse with the immunotherapy, but survival was better. And the overall survival improvement was 4.5 months. And you're going to see this over and over again, this 3 to 4 month thing. And we're going to come back at the end, the cost of getting that 3 to 4 months. So here's immunotherapy, very well tolerated. And then FDA didn't want to approve it until a second trial was done. And the nice thing is the results of the second trial were exactly the same as the smaller first trial. So what about anti-androgens? So this is my greatest accomplishment. I demonstrated that the cancer that comes back in spite of a castrate level of testosterone has normal levels of androgen receptor, which makes no sense. The androgen receptor should have gone away because it wasn't stabilized. And we proposed that the cancer was making its own testosterone, which turned out to be true. People thought I was nuts when I looked at this, and it's true, and that has led first to the theory that the androgen receptor was responding to castrate levels of DHT by hypersensitizing itself. So it was there in normal amounts because of those molecular changes. Turned out that wasn't quite right. But by blocking, using enzalutamide and anti-androgen to block whatever castrate levels of testosterone was there, you actually got a better response. And the small molecule enzalutamide does much better than the bigger molecule, older bicalutamide, also called Casodex. And this just shows how enzalutamide is better than bicalutamide in both PSA response and progression-free survival. So now we know that the cancer is actually making its own testosterone. So rather than block its effect at the androgen receptor with an anti-androgen, why don't we just get rid of the cancer's ability to make that? And we showed this was true first by radioimmunoassay, and then by mass spec, and then another group proved we were correct. And so this is why inhibiting the production of DHT is difficult, because there's so many different ways that a cancer can make it. And common to the pathways is CYP17A1 is the first step in androgen metabolism from a progesterone intermediate. And there are 3 drugs on the market that block this enzyme, and abiraterone is the one who's come to FDA approval first. And so when used before docetaxel, it extends life expectancy by 3.4 months. So remember my recurring theme. When used in men who failed abiraterone, it also extends life expectancy by 3 months. Now the problem is there are multiple mechanisms for resistance to abiraterone, and my lab has published 2 of the mechanisms. But the cancers are really smart, and they find a way to get around an inhibitor. And I'm going to skip this. So they find a way to get around inhibitors. So now docetaxel is the standard of care I mentioned earlier for first-line chemotherapy given with androgen deprivation therapy. When you fail androgen deprivation therapy, whether you've had docetaxel or not, it's probably the standard of care first-line chemotherapy. And the reason for this is it was shown to extend survival when compared to mitoxantrone a number of years ago, 2004. This was the first FDA-approved drug for the castration-recurrent prostate cancer. The extension of survival here was 2.4 months. And it also improved quality of life on top of extended survival. With symptomatic CRPC, now we can consider, once docetaxel has failed, using the new agents. And here's abiraterone improving the overall survival from 10.9 months to 14.8. How many months is that? 4 months. And enzalutamide does essentially the same thing. 4-month improvement. And here's the abiraterone drug in 4-month improvement. So then what happens if you failed docetaxel, and perhaps now you've failed enzalutamide and abiraterone? Well, cabazitaxel has been approved for docetaxel failure. And it's a new semi-synthetic taxane, and the company was not real enthusiastic about supporting this clinical trial, but did anyway. They didn't think it would be successful, and darned if it wasn't. It's called the Tropic study, and here's the extension of survival in yellow, 3.4 months. And then if you have symptomatic CRPC, in spite of all of this, and you have bone mets, you can also try and control the pain from the bone mets, and you can do this with different radioactive compounds. And the new development here is using an alpha emitter, rad-223, because it's safer, it penetrates tissue less, and so it causes much less collateral damage. And here again is the pivotal trial that led to FDA approval. The survival curve looks about the same, and the difference, the improvement in survival was 3.6 months, so I'll round off to 4 months. So this is what castration-recurrent prostate cancer looks like. This is almost as bad as the molecular stuff that was talked about yesterday and earlier this morning, where you have a whole bunch of different things, and you're going to have to depend on the patient to help you decide what to do. So why don't we make a pathway? So why are they needed? So now I'm getting into the philosophical stuff. So the main problems in prostate cancer, I hope I've convinced you, is that overdetection leads to overtreatment. So we got to prevent overdetection by using PSA appropriately. And then we got to, when we find low-risk prostate cancer, we got to resist the urge to treat it. Then patients and doctors and insurance companies are all obsessed with this thing that if it's new, it must be better. And we have to resist that American temptation. New CRPC agents are expensive, and their sequence of use remains completely uncertain. Then hospitals, physicians, insurers, and the government are all rewarded when more stuff is done to more patients. And that, you cannot get away from that. There's no other country in the world that spends as much money as we do, and we're down to 18th in life expectancy. So we're doing something wrong. So let's look at the real world. Use of PSA. This is a no-brainer. Don't do it in really old guys, especially when they're sick. Men greater than 85 who've had a PSA in the last year. So this is from the National Health Interview Study done in 2000 and 2005. So 25% of men over 85 had an early detection PSA in the last year. Now, is that unbelievable? So it must be because all the doctors are greedy. So look at the U.S. Department of Veteran Affairs. There's no greedy doctors there. They were even worse. 36% of the men over 85 had a screening PSA. So what do we got to do here? Well, we got to stop including PSA in routine annual labs. And there's a plethora of guidelines, pamphlets, internet, video, all kinds of stuff trying to educate people about don't do this. But one way not to do it is pathways. What about active surveillance? What's its use in the real world? So where we were was about 67% of the men with NCCN low-risk prostate cancer and life expectancy less than 10 years were treated in the SEER Medicare analysis in 2004 to 2007. So 2/3 of these men were treated when none of them should have been. The U.S. savings would be about $1.3 billion if we just changed that from 100% treatment to 20% treatment. Where are we today? That's the nice little picture on the right, and there is hope. Because as you can see, the little aqua bar on the right, we may be up to 40% of men with low-risk prostate cancer being managed with active surveillance. Although I remind you, that should be close to 100%. But we're making progress. Where we need to go, there's a very nice paper published just recently that indicates that if you do simultaneous consultation instead of linear consultation in Boston, that you can increase the chance of patients choosing active surveillance. And so this speaks to the need for a multidisciplinary approach to this and, again, to pathways. Use of IMRT in the real world. This is my favorite. Okay, this is if you are a urologist who has purchased a radiation machine. This is the distribution of your low-risk cancer patients being subjected to the various options for management. Okay, this is if you don't own your radiation machine on the right. Now it gets even worse. You think that's bad? No. This is self-referral against an NCCN member institution. Now look at the active surveillance and look at how much fewer men are being treated. So this just shows that there's something other than what's best for the patient and what the patient prefers when ownership of a radiation machine is so important here. Here's my fellow robotic surgeons. I love this. Robot-assisted surgery made me famous. Bringing it to Brighton makes me proud. There's nothing better about a robot. It's just, one famous quote is, "A fool with a tool is still a fool." So I hope I've told you here that management of metastatic cancer, it doesn't matter at all whether you do an agonist or an antagonist. And also, you should never do complete androgen blockade. And we should use intermittent hormonal therapy more often because it's cheaper and improves quality of life and doesn't impact survival at all. And giving additional treatment at the time of initiation of ADT extends survival. But we got a fundamental problem here, and that's back to this Volkswagen. And this is the cost at Roswell Park at administering these different agents. And what I've used here, I made some assumptions because I'm a urologist and I don't understand exactly how this is done. But I used the registration trials and I stopped the drug at the mean time to progression. So I assumed every patient stayed on it till they progressed, which we know is not right. And I assumed that every patient would get the mean extension of survival that were reported in the registration trials. And I assumed that the patient completed the planned courses of CYP-T and RAD223 and didn't get any more. And so these are the costs of treatment. I've already beat the living daylights out of everything that extends survival between 2 and 4 months. And if you add all that up, it costs $500,000. And this assumes that every patient got every treatment and had the response. But we know that some of these, when you fail one, like if you fail abiraterone, you won't respond to enzalutamide and vice versa. So that's my little nutty analysis, but here's some from people who know what they're doing. So first bullet, all treatment strategies greatly extend a commonly assumed societal willingness to pay threshold of $100,000 per year of life saved. And this is from the healthcare economist literature. And so this was talking about prostate cancer. So improvement in this situation means that we either need better treatment or we need cheaper drugs. So in my opinion, we need cheaper drugs. So in the clinical scenario, in various clinical trials will teach us about sequence and will also develop biomarkers of response. I just listed a whole bunch of unanswered questions that are going to be important to trying to figure out how to realize a survival of benefit at minimal side effects and at a reasonable cost for these about 17,000, 20,000 men dying of prostate cancer each year. Now, we also got to look at the real world. So if you look at the literature, lots of people say African Americans don't do as well with prostate cancer because they get inferior treatment. So we actually looked at that. And in the state of North Carolina, in our North Carolina-Louisiana Prostate Cancer Project, which happens to be the largest population-based study of prostate cancer ever conducted, it remains so to this day, there were no racial differences in the receipt of NCCN guideline-compliant care. So I was very, very happy to learn that. And we controlled for NCCN risk group where most studies do not. And if you control for risk group, the racial differences in receipt of care went away. And then we confirmed that with a different analysis by a different research group using a completely different methodology. And one interesting thing they found, they looked at treatment regret. And the patients who were presented all the treatment options based on their NCCN risk category and then had side effects, they didn't care because they were properly informed. Again, advocating for pathway use. So what are we doing with pathway development in this complex disease of prostate cancer? So I participated in a 3-year project that was academia, community, and insurer pathway development. It was supposed to be 2 years. 1 year to do a prostate cancer early detection guideline and a 2nd year for treatment. The early detection guideline took 3 years, and then the insurer decided that they had had enough of this and didn't want to weather 3 more years of arguing, which probably would have been 5 or 6. I've personally worked with American College of Surgeons. I'm involved in that McKesson thing. And then I've listed 4 others there that I'm aware, I have no personal involvement, but I know are underway. So there's a lot of stuff going on in the prostate cancer space. But what about patients? And this is the last thing I want to come back to that Alan talked about. So why do guidelines and pathways matter to patients? And I am just blown away about the financial burden that we cause for our patients. And this burden comes in copays, which is what most of us have talked about at this meeting, but it extends way beyond that. It goes to their belief that nutritional supplements or alternative medications are worthwhile. It has to do with their travel for treatment, which has been talked about, their time lost from work. But what we often forget about is a lot of these patients are elderly, and they don't have someone also elderly, and they're asking their children to take off from work and take them to their appointments. So this financial burden has been enhanced by these new agents for CRPC. And many of them come with very high copays. Fortunately, most of them are oral agents. So the capacity for dealing with these new costs of prostate cancer care are felt disproportionately by those who are socioeconomically disadvantaged. And what happens to these people is they withdraw their savings, they sell assets, they forego recommended treatment. And that's a big one. They don't show up for what is relatively non-toxic and can help them. They decrease their work hours, they change to a lower paying job, and that's them and their caregiver, and they may lose their job. And many take out second mortgages or loans to pay for their care, and many declare bankruptcy. So the end-of-life care support study said that 20% of family members, that's not the patient, 20% of patients had their family members stop working to attend to their cancer treatment. 30% of families lost all their savings, and 30% spent more than 10% of their household income on care in an end-of-life situation for palliative care. So palliative care is not inexpensive. So this was shocking to me. And among the cancers, they looked at the 7 most common cancers in America, and I was surprised to see that prostate cancer impacted the family more than any of the other 6. I would not have thought that. This is a slow-growing disease. And financial stress occurs throughout the family. And so we really need to pay a lot more attention to the patient and, more importantly, their family, especially when it's older patients that are dealing with this family problem of prostate cancer. So what I hope I've told you here is that right-sizing prostate cancer early detection and treatment is challenging, but needs to be done. All appropriate treatment options, especially active surveillance, need to be discussed. And the newer treatments need to be evaluated critically and compared carefully to the older treatments to make sure they really are better, not just make better highway signs. Treatment recommendations should not be influenced by any business or personal interest of the care provider or the healthcare system. And the treatment guidelines and care pathways done correctly represent a wonderful opportunity to improve efficiency, quality, and outcomes while reducing the costs and suffering from prostate cancer, and I would pose all other cancers. Now, the simpler conclusion is this, and this is what we don't want to have happen, where we're doing things that, send our patient, well, you wouldn't want to send them to Barbados today, but you get my point. Okay.
Thank you. So questions, I have a couple, but I'm not seeing anybody rushing to the microphone, at least. Oh, thank you, Ira.
Thanks for that great lecture, and I think one of the things that wasn't said, but I think a lot of us in the business understand, is that in metastatic prostate cancer, the treatment decisions are split between urologists and medical oncologists, not evenly, and that has geographic differences and sometimes socioeconomic differences or whatever. So you have to speak to 2 different audiences. So I share your frustration in trying to get unity in appropriate therapy choices. My question is really just to ask if, in doing the economic analytics, that was one of your end summary slides, looking at treatment for therapy when people actually did the optimal choice of ending treatment at the time when you would see the median of benefit. Has anyone talked about doing this in the future when some of those agents become generic? Because one thing that happens is that a lot of therapies are considered new and groovy. Then when they become generic, the prices fall, but you don't really see it because then the pathway adds more newer agents. So you never end up seeing the ultimate economies of the previously new therapies. So is anyone doing those analyses?
Yeah, so the last time I looked, there's about 70 sequencing studies undergoing on CTSU, and they're going to be complicated by the addition of new anti-androgens and new androgen metabolism inhibitors. And so our fascination with new is going to persist. But that's why I made the point that any newer therapy needs to be critically evaluated, not against placebo, but against standard of care. And we need to hold the clinical trialists to this standard.
Great, thanks. Yeah, I just wanted to emphasize that all is not lost in terms of economics.
Yeah.
So at ASCO, they presented the enzalutamide study, and then had a commentary on the relative cost of docetaxel versus enzalutamide. And the docetaxel was 6 months, or 6 cycles, really.
6 cycles.
So it would be 18 weeks, rather than you had 10 cycles. And $78,000 seems awfully expensive for 6 cycles of a drug that probably would cost $1,500 a shot. So whether that's overestimating or not, but there was a dramatic difference between enzalutamide and docetaxel in that situation in terms of cost per year of life.
Yeah, so the numbers that I get are the drug plus administration cost at Roswell Park. So that slide has been shown in multiple forums and picked apart by many people, and most people say it's pretty fair. But again, it may not be accurate because I'm not a medical oncologist.
Yeah, so when we do it, we normalize it to ASP or Medicare to make sure that we're equal and use that as a base and people can figure out their fee schedules. And presumably Roswell Park, maybe not, is charging Medicare for Medicare patients, but some sites, if it's one of the original NCI cancer centers, can make their own fee schedules. Like that may not be reflective of real-world differences in cost.
Well, you can go to Uganda Cancer Institute and get docetaxel for $15 a dose. So that's another alternative to make this cheaper.
So I have some questions for you related to some data that we actually have from, I mentioned it in my talk, and I was wrong. It wasn't 1,000 prostate cancer. It was in the total sample, about 150 of those were actually caregivers. So I'm going to just give you some data to react to from a sample of about 750 prostate cancer patients. And this was done in we haven't released these data yet, but it was done in collaboration with several other prostate cancer advocacy groups. But I think it complements some of the things you were saying. And my ultimate question is, how have you thought about or have you incorporated ways to address some of these issues in the pathway protocols? And it sounded like you had, so I was curious if you could maybe elaborate on that a little bit. But these are related to side effects, and so it's fresh on my mind having read, there's a lot of open-ended questions, and I read 750 of them, and I was surprised by the amount of decisional regret in the comments that patients made. And I already mentioned one of them about the frustration about pain, and the being asked about pain in this population when what they experience is something different. So I'll give you a few statistics, and again, my question really ultimately is, can these, how do you incorporate the side effect conversation as part of the pathway protocol so that this patient population in particular is more informed about the side effects? And so I'll give you some numbers. About 30% of patients said that their doctor never asked them about the risks and side effects that were most concerning to them when considering the treatment options. I'm sure you're not surprised by that.
Not at all.
We also had about the same percentage that said that they were uninformed, to some degree uninformed, about the side effects associated with different treatment options. About 30% said that. When asked, did their doctor ask them to share their goals related to different treatment options? 42% said no. They were never asked about what their goals were related to treatment options. And then related to side effects, when similar questions as with the breast cancer population, what type of side effects did you actually experience and which ones were most severe? Overwhelmingly, 40% of patients said, the side effects that they experienced were erectile dysfunction and decrease in sexual desire. The next thing on the list was like 10%. pain was 3%. So again, this sort of illustrates why this patient population in particular, the emphasis on the quality metric around pain and documenting pain for this patient population is frustrating because what they're experiencing a lack of information up front about side effects, and then as they go through treatment, there's not a lot of conversation or documenting or addressing the side effects that they're actually experiencing. Instead, they feel like the emphasis is on pain. So has anything been done, have you thought about ways or have you incorporated any of that sort of side effect conversation and the differences in side effects into the pathway protocols themselves?
So in the pathway protocols, all treatments, their potential benefit and potential risk need to be discussed, and they're on a kind of a menu. We've been doing that for over 20 years. What is interesting is that many of the community then responds by doing the same, and they produce a boilerplate that gets pasted into their notes. It's very important to ask the physician what the physician thinks he or she did, and ask the patient what they think the physician did. And we have studied this at UNC extensively with Merle Michel, and there are two very different things about what the physician thinks they did and what the patient says they did. And it's been fascinating. So we audio taped all these counseling sessions and analyzed it. And then it also depends on socioeconomic status and somewhat on religiosity and ethnicity of how you want your information delivered. So you can go on and on about differences in this interaction. But most physicians are kind of smart. They went to med school and stuff. The average prostate cancer patient may not be as educated. And we found that the upper socioeconomic level patients wanted data, and the lower wanted experiential information. And if you can actually teach physicians to do a better job of having these interactions. But I mean, this is just a whole can of worms that needs data. I love to quote my boss from Hopkins, Don Coffey: if you can't dazzle them with data, baffle them with bullshit. And we need more data to inform pathway development.